Alrighty, so we're going to go through what do you do when you have a heart abnormality? What should you be looking for? What should your process be? At least just so you have some guideline. Like CSI, everybody knows what CSI is, right? Crime scene investigation. So we're going to do ASI, abnormal sonographic imaging guidelines. What additional images do I need to document? Where else should I look? What labs could give me additional information? And is this an isolated finding? So these are the questions that you need to answer as you're looking at this baby. So ASI, start your list. Where is the defect? What organs are abnormal? Describe the location and appearance. What is the gestational age? Because some of these defects can be gestational age dependent. There can be some normal variants, especially in the first trimester with the embryo. And then is it a singleton or multiple gestation? And just start your list. You have your questions. You want to answer those questions before you go and present to your physician. How many other abnormalities do I see? Because the more abnormalities you see, then the greater chance that this could be associated with aneuploidy or a genetic syndrome. Check your environment. Is there polyhydramnios, oligohydramnios? And then looking at your biometry, anatomy, and then Dopplers if appropriate. Is the anatomy and the Dopplers, are they consistent for the gestational age that's assigned? Is one segment of the baby small or enlarged? Go through, review your maternal history, maternal and paternal age, AMA versus advanced paternal age, any pregestational diabetic, any history of hypertension, seizure disorders, any daily meds, and then any previous surgeries of the uterus. Echogenic cardiac focus. Everybody's seen these, right? And the bane of our existence. So it can be multiple or it can be singular. If they're bilateral, they do have an increased risk of aneuploidy, specifically trisomy 13. If single and a low risk population and no other markers, everything else looks normal, then it's just considered a normal variant. So again, getting your information. Is this woman at any other risk? If she's less than 35 and you don't see anything else, it's probably just a normal variant. But you have to make sure that the anatomy of the heart looks good. So here we're looking at a cross section of the chest. Here's the spine. Apex is pointed towards the left like it should. Most common site for echogenic foci is in the left ventricle. And when we look here, we can see there's like 3 or 4 little echogenic foci within there. And in order to qualify as an echogenic focus, it should be as bright as bone and you should be able to see it in multiple planes. You should be not just one plane, because you can actually cause an artifact. You can create an artifact that makes it look like an echogenic focus when it's not. So looking at ventricular septal defects, that's where it's allowing the oxygenated blood to flow from the left ventricle to the right ventricle, increasing the blood saturation in the main pulmonary artery. We're looking at this open defect here. It's the most common heart defect in the fetus at birth, right about 30%. So we're looking right here, looking at that ventricular septum. So here's where your color really helps. And just remember, there's going to be small VSTs that you're never going to pick up in utero because usually the pressure levels between the left and the right ventricle are pretty similar. So unless it's a bigger VST, if it's just like, think of like a colander, a spaghetti colander, where if it's very small and multiple, you're not going to pick those up. What we're looking for are the larger defects and where we can actually see blood flow across that septum. The other thing you can see when you have VSTs, you can see how the ends have that little bright echogenic area. Because it's surrounded by fluid, what's the best transmitter of sound is fluid, so you get a lot of the echo stopping at the area of the septum. So if you start to see this bright area in the septum, you want to evaluate the septum perpendicular to the beam. That's going to give you the best evaluation of the septum. I know we all like to look at it in the apical view, but actually in that, the transventricular view is the best way to look at the septum. So if you can try to get it so that it's perpendicular to the beam, that's going to be your best way to look at it. But then you put on your color, and then you can see that there is flow across that septum. Again, looking at that bright little echogenic area and a little bit of color. So we see the spine here, always going back to where is the spine. That's why you need to keep the spine in view when you do magnify up or zoom up on the heart. Make sure that you keep spine in that cross section of the chest. So atrioventricular septal defects, that's where you have this crux or the center of the heart that can be absent. It has increased association with aneuploidy and heterotaxies and complete heart block. 40% of babies with trisomy 21 are going to have this type of AV canal or defect. So when you see this, start looking for other signs. For trisomy 21, that would be the short humerus, the short femurs, the short nasal bone, increased nuchal fold. So the more things you see, the greater the chance that there's some chromosome abnormality going on. So this is when the valves are open. I mean, there's a big hole right here in the center. You want to make sure that you're watching it over time. So we see the spine here, anterior wall. This is going to be the left wall and then the right. So here's the spine, apex over towards the left. But you can see, look at those little bright areas. They're just telling you, look at my septum, look at my septum. It's attracting your eye to that area of the septum here. So this one was referred just for a 37-year-old first pregnancy. She had a negative NIPT. Everybody know what NIPT is? Non-invasive prenatal testing. It's one of the maternal screens where you're looking for fetal DNA within the maternal blood. So she had a negative NIPT, and a lot of these women, it's not explained to them that just because you have negative NIPT doesn't mean you're not going to have an anatomic defect. It's screening for chromosome abnormalities. So she was referred for a large heart. So we're looking at a cross-section of the chest. So what are some of the things that we see? Well, it looks like there's some tissue edema. This is the area of the spine. This is the apex over here. So if we were to draw an imaginary line here from posterior to anterior, where's the apex of that heart? First thing that should attract your eyes, look at the cardiac axis. This is left atrium, this is right atrium, this is left ventricle, and this is right ventricle. Spine is here, posterior to anterior, left to right. Remember, we're always looking for that descending aorta too. The descending aorta should always be to the left of the spine. So we can see left atrium, right atrium, foraminal valley here. And this baby started to get episodes of SVT. It wasn't continuous, it wasn't sustained, and we could see there was a little pericardial effusion. It progressed to high drops. What happens when any baby develops high drops? Their outcome, their prognosis goes down. So this is our differential. So what do you think it is? Just a large right atrial septum with an ASD, atrialized right ventricle with Epstein's anomaly, hypoplastic left atrium, or hypoplastic left heart syndrome. So was the right side big or is the left side small? And Jill was telling you that the size of the heart should occupy about 1/3 of the chest. How much of that chest was occupied with heart? Greater than 50%, so that heart is enlarged. A, B, C, or D? So A, huh? Well, let's look at this. So here we've got left atrium, there's right atrium. Look how big that right atrium is. This is left ventricle here. And look how these leaflets are displaced into the right ventricle. So this is an Epstein's anomaly. So you have part of the right ventricle becomes atrialized because of the displacement of the valves into the right ventricle. Look at spines here. This is almost at a 90-degree angle of that apex in the heart. So this is one of those heart abnormalities where the apex is way over towards the left side, and Epstein's anomaly is one of the heart anomalies that goes along with that apex being at a 90-degree angle in the chest. So look, there's left ventricle, there's right ventricle. All of this is going to be right atrium and part of the right ventricle being atrialized. So this is an Epstein's anomaly. But look how big that heart is. I mean, it's occupying about 80–85% of the chest. So again, size of the heart compared to the chest, and where is the apex? Looking at that cardiac axis, it's your first clue that something is going on. Okay, our next one was AMA, advanced maternal age. So it just means our maternal age is going to be 35 or older at time of delivery. It's her first pregnancy. She's referred in just for an anatomy scan. So looking at the head and looking at the back, looking at this chest, we already see that there's some high drops here, a little fluid. There's the liver, a little bit of the bowel. Now this is a transverse of the chest. So spine is here, so posterior to anterior, left to right, because there's the left atrium with the pulmonary veins there, and aorta to the left of the spine. So what about our cardiac axis? So this is called mesocardia, when the apex is straight up. And then look at the echo texture of the lungs. They look a little bright, huh? And I'm going to do a coronal view of the chest, so we're looking from right side to left side. Look at the diaphragm. Kind of bulging out, downward, displaced inferiorly. And then looking at this. So what do you think this could be? This dilated structure coming from the area of the neck down into the chest. It's a dilated trachea. So it's our differential. So bilateral, microcystic, CPAM, or congenital pulmonary airway malformation. Bilateral diaphragmatic hernias. Pulmonary teratoma, or chaos, congenital high airway obstruction sequence. So again, the first thing that you saw is that the apex is off. This is a chaos. So what happens is, the lungs are producing fluid. If the fluid has no way to get out, it starts to enlarge. It's just like anything. If it's microcystic little areas, the lungs look echogenic because it has all these little spaces that are filled up with fluid. So it looks bright. And then you actually have inversion of the diaphragm. So now the lungs are filling up with this fluid that can't get out. So what happens then is the heart is being moved midline because both lungs are filling up. So the heart gets displaced to the middle of the chest. And then this is a dilated trachea here. So it has no way to let that fluid out. Almost all of them have ascites. And this is one that if you don't pick this up, this baby will die when it's born because it has no open airway. So it's important to make this distinction so that they can do what's called an exit procedure, where they'll deliver the baby halfway, establish an airway, and then go ahead and deliver the rest of the baby. So they maintain that maternal connection, keeping the blood flowing, the oxygenation going until they can establish an airway for the baby. Okay, this one was a 31-year-old, gravida 3, para 2. She comes in for late prenatal care, no significant family history. This is like a parasagittal of the chest. It's looking at the head, the neck, anterior to posterior. It's over towards the left side. There's the stomach, part of the diaphragm, and this is the chest. Now this is a transverse of the chest. Stomach is here and then up into the heart. So we see a lot of these little bright areas. We look up into the head. I see some bright areas. And then looking at the transverse of the chest again. So looking from left to right, left to right. You see I've got these little numbers on here. It's wonderful when the machine labels it. It'd be great if it could do it automatically. But you can see I've actually counted 5 different little echogenic collections. And this is looking at that sagittal scan from left to right. So the diaphragm is intact. So again, left, so we're over here by the stomach. There's diaphragm. We're going through the heart. And with color. So again, spine here, so posterior to anterior, right to left. Just looking at this color, look at the contractility of that muscle. Do you see how poorly contracting this left ventricle is? It doesn't have that good squeeze. That's what we're looking at. Not only rate and rhythm, but also looking at the contractility of the muscle. So let's look, what are our choices? So pericardial teratoma, rhabdomyoma, fibroma, hemangioma, myxoma, or a large echogenic foci. Pericardial teratoma, huh? Rhabdomyoma. So the more that you have them, the rhabdomyomas are the most common cardiac tumor that we see in utero. Usually your teratomas are going to start at the apex and involve the wall and grow out. These are actually within the ventricle. Rhabdomyoma, again, is the most common fetal cardiac mass, has a high association with tuberous sclerosis. So remember, I looked up into the head, you could actually see little tubers up in the brain. So if you see rhabdomyomas and you see multiple rhabdomyomas, make sure you're looking at the head, and then also later on, sometimes you can even get them in the liver. So there's these little tubers, these little masses. Pericardial teratoma usually arises from a stalk near the apex of the heart. These we could see them in all different parts of the heart, and has a high association with pericardial effusion. Fibroma is usually from the left ventricular wall. Myxoma is a more common cardiac mass in adults, so we usually don't see that in utero. But rhabdomyoma, if you see a cardiac mass, guess rhabdomyoma. 90% of the time you're going to be correct. And if you see a rhabdomyoma, you're actually looking at the contractility of that muscle. I mean, not only the rate and the rhythm, but I mean, how is the muscle contracting? Because with these large rhabdomyomas, it can affect the contractility of that heart. So this one was a referral for just can't see the four-chamber heart. And if you're doing screening ultrasounds and you can't see a normal four-chamber, you've done your job. Your job is to know, does it look normal? Is the heart in the right place? Do I at least see that four-chamber heart and that three-vessel trachea view? If those look normal, you've done your job. And if you can't see that, send them on. She's 29 years old, gravida 3, para 2s, there's her 2, abnormal four-chamber heart, or just couldn't see the four-chamber heart on the outside scan. Also had a dilated right renal pelvis, no other significant families history, and negative quad screen. So these different screens are looking for genetic syndromes. Does not tell us anything about the anatomy. So that's what I think people forget. They get these blood screens, which is looking for aneuploidy. It is not screening for anatomic defects. So that's where we come in. So this little cross section of the chest, we're looking from posterior to anterior, left to right. So we do see a little bit of a pleural effusion there. But just looking at the heart, well, it's about the right size, but looking from the left to the right side. So is the left big or the right small? And then left atrium, right atrium. Apex pointing towards the left like it should be. There's a cross section of my descending aorta. So what do you think? Differential cardiac teratoma, rhabdomyoma, echogenic foci or focus, hypoplastic right heart or hypoplastic left heart. Just looking at the color again, apex down. Here's color over here on the left. This is on the right. Look how thickened that ventricle is over here. Again, right side, left side. Hypoplastic right heart syndrome, you are correct. I mean, look at how thickened that is there. A little pericardial effusion there too. So apex, so we're just looking, where is the apex? What does the structure of the heart, the morphology of the heart look like? What do I see? What looks normal? What doesn't look normal? So it's just the process of going through what do I see, what don't I see? So that's a hypoplastic right heart. Because that muscle is contracting, 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 and then it's not able to move blood through it, so it's just getting thicker and thicker and thicker. All right, so this next one is a 28-year-old, gravida 2, para 1. She declined genetic screen, so she's here for her anatomy study. This is a cross-section of the chest. There's the spine, so posterior to anterior. This just magnified up and in real time. So I've just zoomed up a little bit more. So looking at the posterior to anterior. So where's the apex of the heart? In the center. So yep, so it's mesocardia. And yes, should we see a little break in the chest here? This could be a problem, huh? So just magnifying up again. So these are your atria here. These are ventricles starting here and extending out to here. And with color, anything with the heart, once you look at it in 2D, put color on it. Again, just adding more information. So you can see how the ventricles are elongated out. This is the MRI. This is umbilical cord, and this is actually the ventricles, the apex of the heart. So this is our differential, ectopia cordis, pentalogy of Cantrell, body stock anomaly, amniotic band sequence, congenital diaphragmatic hernia, or pulmonary sequestration. All right. So this is ectopia cordis. So there's a sternal defect, a congenital abnormality of the sternum, a defect in that anterior chest wall, and the heart protruding through the anterior chest wall. So now the differential between this And pentalogy of Cantrell also has other abnormalities. This is all this baby had. So hypoplastic left heart syndrome, or HLHS, it's the most common cause of neonatal death. So most common in occurrence is going to be your VSD for congenital heart defects, but the most common cause of neonatal or infant death from heart defect is going to be your hypoplastic left heart syndrome. So we can see the apex here, looking at right ventricle, right atrium, left ventricle, left atrium. And so we can see this small, thickened left ventricle with a small aorta. So again, looking at the spine, so posterior to anterior, left to right. Again, looking at the contractility, you see how the right side is contracting well? Do you see the left side? The myocardium on the left, if it's not able to move the blood through there properly, it starts to get real stiff, and you get what's EFE, the endocardial fiber elastosis, this little bright rim. That's letting us know that there's been cell death in that myocardium. So left atrium, right atrium. Just look at the difference between the contractility from the right side to the left side. So, and then just have pericardial effusion. So put color on it. I mean, look at the flow here on the right versus the left. So this one we actually had mitral stenosis. There was no flow from the left atrium to the left ventricle. The flow that we're seeing over and the left ventricle, the only reason we even see left ventricle is because there was a VSD also. So when you see your left hypoplastic heart, not all of them are going to be with that left ventricle really small. So that's why I was trying to show this one, that you can see the, comparatively looking at them size to size, it was a little bit smaller than the right, but you can still see the left ventricle because they can have these VSDs. So this is another baby. So posterior to anterior, apex pointed towards the left. Looking at the chest, the heart size. So the heart occupies about 1/3 of the chest. So we see right ventricle, right atrium, left ventricle, and left atrium. What can you tell me about the right ventricle? The right ventricle is a little bit enlarged, comparing it to the left ventricle. See how small that left ventricle is? And what's the other thing we're seeing? The EFE. So that's letting us know that that left ventricle has not been working properly for a while because we already have EFE. So we've got the right side of the heart enlarged, the left side of the heart small. Let's put color on. Look at that. So what do I see? Where is it at? What is the color flow through that heart? So this is another example of your hypoplastic left heart. So tetralogy of flow is when you have pulmonary artery hypoplasia, which is going to be our curved arrow. You have a VSD, and then you have narrowing of the pulmonary outflow tract. So you have the overriding aorta. So because of this VSD, then you have blood flow that's coming from the right side of the heart, actually going, some of it going out through the aorta, and then you have a small pulmonary artery coming out. Transposition of the great vessels or arteries. You have aorta is arising from the right ventricle, and then the pulmonary artery arising from the left ventricle. So that's why you need to know the morphology of the ventricles. The moderator band should be in your right ventricle, and the apex of the heart should be formed by that left ventricle, and it should be more conical in shape and smoother wall. And then what vessel is coming out of the heart, and where does it divide? This is the one with your transposition. If you go to that 3-vessel view, I know Jill and I will say this time and time again, that 3-vessel view is going to help you time and time again. You're not going to see 3 vessels. You're going to only see 2 vessels up there because that pulmonary artery came out of the left ventricle and then bifurcated right away. So here we have the aorta coming out of the anatomic or morphologic right ventricle, and then we have the pulmonary artery coming out of the left ventricle. So this is your D transposition. So this vessel comes out and then is bifurcating right away. So this is like looking at left ventricle, right ventricle. And there's that pulmonary artery coming out of the left ventricles, the posterior ventricle, and bifurcates right away. And then this is the ascending aorta coming out of the right ventricle. So you have parallel vessels as they're exiting the heart. So those vessels can be parallel, it's just where is it supposed to be? When they're coming out of the heart, right at the interventricular septum, they should be crossing each other. When you go to the 3-vessel views, then it's okay for them to be parallel. But at this part of the heart, the center of the heart, those great arteries should be crossing each other. They should not be running parallel. So again, looking at left ventricle, this vessel comes out and bifurcates right away. So that's the morphologic pulmonary artery arising from the left ventricle. And then this in real time. So we have right ventricle, left ventricle. That's the aorta arising from the right ventricle, and then this one bifurcates right away, so that is your pulmonary artery. So it's important to look at those vessels as they're coming out, which one is connected to what ventricle, are they connected to the correct ventricle? So again, we always keep that spine as our reference point. And then again, so we've got right ventricle, left ventricle. This vessel coming out, comes out and bifurcates. Remember that aorta should come from the middle of the heart. It has the tighter curve, comes up and around and down. If it's coming out and splitting off, that is the pulmonary artery coming out of the left ventricle. So these vessels are parallel. You see as I'm just sweeping through. This pulmonary artery coming out of the left and aorta coming out of the right. Coarct, it's hypoplasia of the ascending aortic. The ascending aorta, blood flow in the descending aorta is narrowed, and mainly right at the site where that ductus arteriosus dumps into the aorta, right there at the isthmus, that's usually where you see the narrowing, right here. So we've got the aorta coming up and around, we've got our head vessels coming off, so right as that third branch comes off, right in this area where the ductus dumps back into the aorta, that's where we get the narrowing. And usually your first sign that there could be a coarct is when you're doing your 20-week study, that the right side of the heart is more than 20% bigger than what the left is. So you may not see that narrowing quite yet, but that'll be your first sign. In the third trimester, it's not as striking because it's normally the right ventricle can be a little bit larger in the third trimester. But when you're doing that survey at that 22 weeks, when that right side of the heart is much bigger than the left is, think of coarct. Double outlet right ventricle, we got both arteries arising from the right ventricle. So we've got both vessels. We see the septum here, but both of those arteries are arising from the right ventricle, and then usually with a VSD. So we're looking at the right ventricle, both great arteries coming out of the right side. And this in real time. Kind of similar to what you had with your transposition, but now we've got both arteries on the one side of the septum. So septum is here, both great arteries coming right out of the right ventricle. So then the truncus arteriosus is when we have the one main, for some reason it didn't divide properly. You have that big caudal truncal artery that just doesn't divide in early embryology like it should. So you can have variants of this as to what branches off where, how they connect, but you have usually an open septum here, interruption of the little VSD, and then that one great artery coming directly over both of those ventricles. Okay, and then one last case. This is just to remind you that even though you're not doing an anatomy study, even if you're just doing a biophysical profile, always look at the head, heart, and kidneys, because those are the things that continue to develop and end up having problems later on. So even as you're just doing your biophysical, just make sure you just kind of look at them. Make sure there hasn't been any big changes. So this one was referred at 33 weeks just for a biophysical profile with decreased fetal movements. She's only 16 years old. She came for late prenatal care. I think the first time we saw her was at 30 weeks. First pregnancy, no genetic serum screening, and no maternal complications during the pregnancy. So we're looking from posterior to anterior, left to right. Looking at our 4 chambers, left atria, left ventricle, right ventricle, moderator band, so that is morphologically the right ventricle, anterior chest wall. And then this in real time. So left atrium, left ventricle, right ventricle, apex, anterior, and then looking posteriorly. Anything catch your eye? Of course, let's put color on it. It's extending down here. So differential on this, left ventricular diverticulum, hypoplastic left heart syndrome, left ventricular aneurysm, or cardiac teratoma. So left ventricular aneurysm. So I mean, this impacts their delivery and how this baby is going to do. Just for us, having looked at it as we're scanning, I mean, I was just scanning and I was like, what the heck is that? So then, you take the time to kind of go back and look at it and go, oh, okay, well, let's get her to Pete's Cardiac and let them look at it. So now we have a plan of care. We know we're not going to let her deliver in her local hospital. She has to deliver, at a tertiary center so that they can look at this and evaluate the heart once the baby's born. So just always looking at the head, heart, kidney. Those are the three main areas that are going to change throughout the pregnancy. So even just a biophysical profile, just make sure you're always looking. So good reminders, whenever scanning patient, perform a quick survey. We can fluid, head, heart, kidneys, and document any changes from your previous scans. So that's an overview of the main abnormalities. I mean, there's multiple more, but it's, this at least gives you the main ones. Any questions? But your job when you're screening, is it in the right place? Is it in the right size? Do I see the 4 chambers? Are those great arteries exiting the 4 chambers the way they should? And is that 3-vessel view normal? If you've done that, if you can answer those questions, you've done your job. And if it doesn't look normal, then you send it on and let somebody else figure it out. You've done your job.